we will dive into the biology of cancer to unlock the secrets that might allow us to defeat it and help our patients. Our guide in this journey is a clinician and a scientist who has a lab at Winship Cancer Institute to his name, Khan Lab, at Emory University. And he is leading a distinguished group of physicians and scientists with research focus on the integration of radiation and immunotherapy. So this is Dr. Muhammad Khan. He received his MD and PhD at University of Tennessee, and he had his residency at Cleveland Clinic. He's now a professor of radiation oncology at Emory University. Dr. Khan, the floor is yours.
Okay. Thank you very much for the honor and the opportunity to talk about some innovative research that's going to impact our radiation oncology patients, not just within the US, but across the world. And thank you for the opportunity, and assalamu alaikum. And I look forward to shedding some more light on a new area that would have an impact. So a little bit of myself, I'm a clinical scientist. I have a lab, I've done mouse work. I've taken that mouse work and actually translated that into clinical trials. And I'll actually present some of the earliest data over the last 10, 15 years of research innovations coming out of Emory that is transforming the treatment of patients across US and across the world. So I'm going to talk about the radiotherapy and how it impacts the immune system in patients, and how we can use it to turn on the immune system and also to turn it off. And I'll talk about that. These are my conflicts. Why is this important? So back in 2009, 2010, if you look at the Red Journal never accepted review articles back then. The first review article that was ever accepted was an article that I wrote on melanoma and how radiotherapy can impact melanoma and the evidence of it. And in that article, I highlighted in 2009, 2010, where radiation might stimulate the immune system, and how the future of cancer, not just melanoma, would be an era where immunotherapy would take foothold. So this is over 15, 20 years ago that I talked about this. So now I think we're in the dawn of the immunotherapy era, and I think there's still a lot of investigation, research, and science that still needs to develop. But I think we can all agree that immunotherapy is becoming a standard of care across multiple cancers. Back then, it was very novel and innovative, and a lot of people were skeptic about it. So this is one of the papers that I wrote highlighting this. I think currently there's still a lot of questions that still unremained that still need to be answered. So I think, to me, if we can understand how radiation impacts the immune system, we can better integrate it with immunotherapy that our patients are getting, and start answering things like, can we expand the role of radiation from where we talk to patients about palliative? We change that discussion and say, hey, potentially it could be curative. So a stage 4 patient was metastatic, or you're doing immunotherapy, and then we add radiation to it. Can we trigger immunity and improve outcomes? Can we take cold tumors like sarcomas and others and convert them into hot tumors so they respond to immunotherapy? And now, I think right now at Emory, we're talking about how do we move radiation in the upfront setting, in the new adjuvant setting, where we combine it with immunotherapy to get better responses, and maybe minimize the need for radiation, need for surgery, actually. And the whole goal is to improve control rates, progression-free survival, overall survival, and then more immunologically objective response rates. And also I'll talk about the second part of my talk, which is using the anti-inflammatory effects of radiation, and start talking about benign indications where we play a role in that. So the whole concept of radiation and how it impacts the immune system has a huge impact that I want to highlight today. So this is my talk where I'll talk about turning on the immune system and how it's relevant to cancer. And I'll highlight all the work that I'll be done in my lab, along with other labs with mouse work. And then more specifically, we'll talk about some of the early results from early clinical trials that I've run here at Emory as PI. So that's going to be the on system we'll talk about. The second part of my talk will be the off system. If you recall, I ran the world's first phase 1 and phase 2 trials for COVID-19, where I show low dose radiation dampens the immune system. It dampens inflammation, it cuts that out, And we published many of these papers in the Red Journal and Green Journal and other journals like that. And now in the US, throughout the US, many hospitals are now starting to take that and say, let's start doing arthritis treatments to calm down inflammation. And I think there's opportunities above and beyond arthritis into other indications that I'll highlight. So let's talk about turning on the immune system. This all is the premise for turning on the immune system goes probably as early as 1953, where this was described by Dr. Moe, where an abscopal effect takes place, where if you radiate one tumor or one area in the body, and some distant site away regresses and goes away. And so this was described, but no one really knew back then what the biology, what the mechanisms, what the immune mechanisms were involved. So it was kind of ignored and neglected. So there's a bunch of case reports that had come out. So so from 1953 to like 2010 and 2009, when I was looking at all of this, there really weren't a lot of like good basic sciences data. There were a lot of case reports, about 40 or 50 case reports that were summarized like in 2011 that looked at Hodgkin's and melanoma and renal cell and how a certain amount of radiation to one area led to clinical regression in other areas. But immunologically, there was very, very limited or hardly any basic sciences data. So when I got together, I built my lab around that concept as early as 2010 and 2011, started thinking about this. And the Red Journal paper that I talked about and this oncotherapy target paper kind of highlighted some of this, but you have to show science. You have to start from the basic concept, which is basic sciences. So a lot of questions, people were skeptical when I talked about this, was it real? So my own team, when I gave grand rounds at Emory, a lot of my medical oncologists and my team member were like, hey, is it real? And is it really immune mediated? If so, what are the immune cells that are playing a role? And how can we model this in mouse? So is there a mouse model that we can use that will translate to humans? And so the question becomes, what dose do we need once we have a mouse model? What is the actual radiation fraction size that is optimal to trigger anti-tumor immunity? And what about the lymph nodes? Should we radiate lymph nodes? Should we not radiate lymph nodes? And then what are the key cells like CD4 T cells or CD8 T cells that are driving this anti-tumor immunity? What if you knock out CD8 T cells? What if you knock out CD4 T cells? What happens to the abscopal response? And what about NK cells and tumor exosomes? Exosomes are those damp molecules that come out that are secreted, after tumors are dying. What role do they play? And then also type 1 interferon is a cytokine that also helps drive anti-tumor immunity downstream and activation of CD8 T cells and other cells. What happens to those signaling? So there's all these questions that were being developed at that time, and we started answering those over years. And then more importantly, as we understand radiation, how do we sequence that with CTLA-4? So checkpoint inhibitors or PD-1 checkpoint inhibitors or 4-1BB and other inhibitors, and can we translate this to clinical trials? And then more importantly, we're developing biomarker now. So there's a one paper we already published that talks about these activated CD8 T cells that may be predictive of someone that has an abscopal response. So once again, this is not my work alone. This is the work of an entire team at Emory and others. So Dr. Rafi Ahmed is a nationally, internationally recognized immunologist who is highly recognized for his expertise in CD8 T cells, has multiple Nature and Science papers. So his lab and my lab work together of understanding radiation biology. And Dr. Lawson is the head of our melanoma group, and he and I worked about patients and clinical trial design and getting funding from pharmaceuticals to make these things happen. So it's really a team effort. What you see is only the tip of the iceberg of all the key players behind the data I'll present. So these are the multiple case reports that you guys are aware of that came out over 1973 all the way on until 2011, and multiple case reports of radiation abscopal effects showing response rates. Here is the review article that kind of highlighted some of the concepts that are at play when you turn the immune system on. So when you do radiation to an environment, what happens to a tumor cell and then make it immunogenic? So number one, the tumor cells themselves will go through changes with the surface of those tumor cells will express these what they call immunogenic cell death pathways, where certain antigens are going to be expressed on the surfaces of the MHC class 1 molecules and MHC class 2 molecules, where the CD8 T cell will come and recognize it and turn on immunity. And also these, what they call damage-associated molecular patterns will also be secreted in the environment that will make that anti-tumor environment more conducive to immune attack. And also certain antigens, cryptic antigens are going to be expressed on the surfaces. And furthermore, I talked about interferon gamma and other cytokines are going to be released in that tumor environment after radiation to make it more immunogenic and allow the immune system to attack and help destroy the immune cells. And more importantly, what happens when you radiate tumor cells, if you pick the right radiation dose in the right environment, you'll actually allow for T cells, especially CD8 T cells, to move in and then infiltrate the tumor environment. And then these T cells are highly active, highly proliferative, ready to attack. So you'll see a lot of cytokines being secreted and help destroy the T cells. And also these T cells go from stem-like cells to more effector-like cells to actually destroy the tumor cells. And then even antigen-presenting cells, those are the macrophages, the dendritic cells, they'll actually move into the environment where radiation is done and go into maturation and activation and actually allow for antigen processing to be more effective and really present that to T cells more effectively. So the entire cascade gets turned on if you do it right. So how do we show this? So we started with the simple mouse work initially. So this is my postdoc, Dr. Tahsin Nusty. He and I worked on this for several years, where we took B16F10 melanoma mouse models, we radiated one side, and we look at out of field what happens. So if you radiate this side, the right side, what happens to the left side on day 10? So after day 10 to day 17, you see the tumors grow if you don't do anything at all. But if you radiate, you can actually see the abscopal response. So here, what you're seeing on the bottom left, can you see my arrow at all or not? Are you able to see my arrow? Where I'm pointing to?
Yes.
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 All right, so this is the area that I'm radiating. So for example, radiation, you can see 10 gray and even 20 gray actually does a good job of controlling the tumor when you radiate by day 17. All right, but it's interesting to see when you radiate the right side, look at the left side of the tumor. This is a tumor that's not radiated, that's out of field effect. And out of field effect, you see if you don't do anything at all, no radiation, the tumor grows not only the ipsilateral side, but also the outer field it grows. But when you do radiation, you can actually see reduction without even doing anything out of field. You see this area where the tumor just doesn't grow at the same rate. So that's the abscopal response. Then what we do is we look at those tumor cells that we radiated. We look at out of the field tumor cells and we take them out and we do tumor microenvironment analysis to look at what T cells are in that environment, the area we radiated, and also in the radiate out of field, what are the T cells that go up? And what we showed, there's a 4-fold increase of CD4 T cells, right? So CD4 T cells are driving it. We also see CD8 T cells. So if you look at CD8 T cells, we see 11-fold increase in the radiated environment, and then we see a 4-fold increase out of field that wasn't even radiated. So this shows you that there's an increase of CD8 T cells that are driving part of the abscopal response. And then when we look at those CD8 T cells, we then look at, are these CD8 T cells functional? Are they actually going to secrete interferon gamma, which is then going to lead to destruction of those tumor cells in the radiated environment and outer field? And we see that. So what you see are two graphs here, and 10 gray is the most optimal radiation dose. So here on in the side that was radiated, you see a lot more CD8 T cells that are interferon gamma producing. And you also see out of field CD8 T cells are higher that are also interferon gamma producing. So these are functional CD8 T cells that are designed to kill the tumor cell, and they're triggered by radiation being done on one side, and out of field effect is seeing it as well. And then when we look at those CD8 T cells, we ask ourselves, are they antigen specific? So if you look at these melanoma cells that we implanted, these melanoma cells are not just any melanoma cells. We introduced antigens in them so that we can do specific CD8 T cells that are looking for those antigens in the tumor that were irradiated. So in the DNA of these tumors, we implanted these antigens, and that's what you're seeing here, the GP33, this is glycoprotein 33 and glycoprotein 276 are actually introduced into the cancer cell lines. So we can look at CD8 T cells that are specific to those antigens. So this shows you radiation express those antigens, and the CD8 T cells are looking for those. And you see that on the ipsilateral side and the contralateral side. And so this shows that, yes, it is antigen specific, it is tumor specific, and these are functional CD8 T cells. And then more importantly, we look at, are they proliferating? Are they multiplying? Are they going to expand and then go out and kill other cells in the body? So that's where we look at PD-1 high and Ki67 CD8 T cells. And then we also look at the memory formation. Are these cells going to form memory and help reduce to long-term eradication tumors? So we see some evidence of a CD44 high granzyme B production, which shows that there is some memory formation amongst the CD8 T cells that are antigen specific, tumor specific, that are triggered on with the radiation in the radiated environment, but also out of field area that we didn't even do anything to. And then we look at this MHC class 1 expression, which should go up because you're causing damage in the cancer cells, and the surface should show these new antigens. So here we have MHC class 1 expression that's increased on the surface of these cancer cells. So this shows mechanistically that yes, radiation is treating anti-tumor immunity within the radiant environment, but also out of the outer field. So, and then we looked at radiation doses. So if you look at these experiments here we looked at different radiation dose, 0 gray, we did 5 gray, single fraction, we did 2 gray times 5, we did 10 gray in 2 fractions, and we did 20 gray in single fraction. So multiple radiation dose and fractionation to kind of get to the point that you need an optimal radiation dose. That optimal radiation dose is 8 gray to 12 gray fractionation size. And the reason behind that is you need this ideal radiation dose to not overdo it and not over destroy the immune system, but also not underdo it. You really haven't damaged the cancer cells enough to allow for the right immune environment to be created. So this whole tumor microenvironment and using radiation to create that is very, very important to having positive results and positive trials. And so when we wrote this paper in 2018, another paper from DeMaria came out 3 years later talking about exactly the same thing that we talked about in 2018, where they talk about using certain doses, 8 gray times 3 or 6 gray times 5, where this is subablative. This is called immune modulation. If you do too much, you end up in this sort of ablative where you're doing immunogenic cell death. And what happens with immunogenic cell death, you've actually caused changes in the membrane calreticulin, HMGB1 release, ATP release, uric acid, cell surface, heat shock protein 70 being expressed. This is not going to trigger immunity as effectively as you would like. But this is important if you're worried about trying to kill every little tumor and getting rid of every micrometastatic disease, then you want to take this route. But if you want to have more integrative approach where you want immune system to do its effect, the immune checkpoint inhibitors to do their effect, and you want radiation to trigger immunity, you don't want to be in that realm where you're trying to destroy every little micrometastatic disease. You're just trying to engage the immune system. And that's the immunomodulation component that's also talked about in this paper. So the other thing we want to do is what happens to CD8 T cells. So like I showed you previously, the CD8 T cells are responsible for the abscopal response. Therefore, if you block the CD8 T cells, the abscopal response should disappear. That's exactly what we see. So here's the unradiated area. If we give 10 gray to the side, you see the abscopal response take an effect. But if you do an anti-CD8, you can see you lose with the radiation and anti-CD8, you lose the abscopal response. And similarly, you see this in the radiated side and the non-radiated side. And then also with CD4 T cells, those are immunosuppressive cells, especially Tregs. If you block those, the abscopal response actually gets better. So once again, abscopal response is mainly driven by CD8 T cells, but it also has a role with CD4 T cells and other cells playing a role. So it's not just CD8 T cells, I think that's the bulk of it, but CD4 T cells also play some role. So then Dr. Ahmed, he published his paper in 2016 in Nature, where they looked at the CD8 T cells that are stem-like cells. These are the cells that respond to PD-1 checkpoint, and these are the cells that actually kill the cancer cells systemically after PD-1 blockade. And these stem cells, they go through differentiation. So initially, they have the ability to proliferate, but they don't have the ability to actually go out and kill the cells unless they get exposed to some sort of PD-1 blockade. They can then undergo sort of differentiation. They move into what's called terminally differentiated cells. They move out into the lymph node, they move out into the tumors, and actually are the ones that actually kill the tumor cells, and they're responsive to PD-1 blockade. So this is a paper published in Nature. So what we decided to say, hey, do these stem-like cell phenotypes exist in radiation? Are they also responsible for the abscopal response? Turns out they actually are, and we proved that. So this was a paper we published in 2020 in JITC, the Journal of Immunotherapy for Cancer. So it's a relatively high impact paper. So this was Dr. Buchwald, who was in my lab at the time working on this stuff, where we found stem-like cells were being activated not just in the tumor environment, but also in the lymph nodes, on the ipsilateral lymph node, and also the outer field lymph node. It was being activated, was being turned on. As you can imagine, we were very excited to see this, that it's not just the tumor cells, the tumors playing a role, but the regional lymph nodes are playing a role. Now the question becomes, do we radiate the lymph node and the tumor? If we do, what happens to the abscopal response? does the abscopal response disappear? Because remember, the lymph nodes is where all the activation is taking place. That's where the CD8 T cells are seeing the antigens coming off and becoming activated. Those stem-like CD8 T cells are turning into terminally differentiated CD8 T cells in the lymph nodes. So if you ablate the lymph nodes and the tumor, you should see a blunting of the abscopal response. So this paper described this beautifully. And this was published. So you can see where we identified the lymph nodes in the mice, and we radiated the flank of the mice, and we radiated the lymph nodes, and showed that there's blunting of the abscopal response. So you can see here where we do the control, and we have tumor-directed radiation, and we have tumor-directed radiation plus lymph node radiation. And you can see where we lose the abscopal response. Here's the abscopal response when you don't radiate the lymph nodes. But when you radiate the lymph nodes, you actually lose the abscopal response, where the tumor still grows after you radiate. So radiating lymph nodes is bad. And we published in 2020. And this just shows, yes, stem-like CD8 T cells are seen in tumors and ipsilateral tumors and contralateral tumors. And we look at the lymph nodes, we also see activation of stem-like CD8 T cells and terminally differentiated CD8 T cells in the lymph nodes as well. And more importantly, is when you do tumor-directed radiation, it blunts all that. So you want to avoid radiating the lymph nodes. Anyways, so that's a lot of basic sciences. I'm going to transition to clinical trials and clinical things. Does it actually translate or not? So if you're thoughtful about your clinical trial designs and you're careful, you should see some positive signals in clinical trials. And I think that's what this is about. So what we did, we did a lot of work with anti-PD-1. Before we did a clinical trial, we wanted to show that radiation in the mouse and anti-PD-1 is going to respond better than either one of them alone. And that's what these experiments were. Here we did radiation to the right side of the mouse, and outer field effect, which is the left side that was unradiated. You can see the green. Green is where we look at radiation plus anti-PD-1 has the best response. It's better than anti-PD-1 alone or better than radiation alone. So you can see the separation of multiple combinations where we show this. And then we look at the total number of CD8 T cells that are antigen specifics. We also show that radiation and anti-PD-1 is the most effective combination as opposed to anti-PD-1 alone or radiation alone. Okay, so this is the most effective combination. We show this. And we presented this ASCO, Astro, and other venues. And we also show sequencing. So the question becomes, how should we sequence it? Should we do radiation first and then PD-1, or PD-1 first, then radiation? We ran a bunch of experiments, and we came to the conclusion that radiation should be done first, which makes sense because you want to change the antigens, you want to change the tumor microenvironment, you want the PD-L1 expression to be high, and you want that whole environment set up so that the immune cells that are responding to PD-1 can get in and have a more effective response. And all of our mouse experiments actually showed that radiation followed by anti-PD-1 should be important. And this is a biology, a very what they call RNA sequence profiling that we did. It's a very big experiment, very expensive experiment. We did that just to show that the signals that are turned on in stem-like cells and exhausted, phenotype cells, those terminally differentiated T cells are different when you use radiation. So you can see like antigen processing, cell cycle, IL-2 signaling are turned on with PD-1 blockade. And then with radiation, you turn on a different kind of combination. You see T cell receptor signaling turned on. You see MDA5 signaling turned on. Type 1 interferon that I talked about before, type 2 interferon signaling, those are turned on with radiation. But when you combine the two, you see this sort of nice overlap with multiple immune activating signals turned on when you combine radiation and anti-PD-1. So you see this. Okay, so I think we're at this slide here. I think the main thing is this relevant to clinical trials? Can we be more thoughtful about clinical trials? So one of the things you'll read, and I think in the Red Journal in 2024 last year, there was a nice review article that came out that summarized all the clinical trials that were done recently in the last 2 or 3 years or so. Some of them were actually negative, all right? And because they didn't take into account about things we talked about, lymph nodes, about picking tumors that are immunosensitive, but instead they focus on tumors that were not so immunosensitive or immunoresponsive and done trials on that just because they were able to. So to me, I think you need to be very thoughtful about clinical trial design if you're going to have a positive result. And I think the number of positive results are far and few right now in the immunotherapy era with radiation, but there are trials that are positive. I'm going to highlight two of them that we've done here at Emory that I would consider as positive, but they're early phase 2 trials, but we need a phase 3 trial, and I'm working towards that as well. All right. So here's one trial that will be presented in 2021, and it's now under review. We've gotten some review articles that are some journals that are interested in this. So we're waiting for it to finally come out. So this is was ASCO. So this is a patient with melanoma brain metastases. As you know, Emory, we're leading premiers in terms of treating melanoma patients, especially melanoma brain metastases. So I ran this trial based on my mouse work that I presented about doing radiation and pembrolizumab for patients with melanoma brain metastases. So patients have to have 10 or less brain metastases, and they have to be eligible for stereotactic radiosurgery, and they have to be eligible for pembrolizumab. And we did this concurrently the same day. So day one, we did radiation. Day one, we did pembrolizumab. So you can see day one, pembrolizumab. We use a standard pembrolizumab dosing of 200 milligram given every 3 weeks and continued for about 2 years. And then SRS was actually 3 arms. I was trying to test what I learned early in my mouse work, whether or not arm A, which is 6 gray times 5, or 9 gray times 3, or the standard RTOG dosing, single fractionation, which one of those would be more effective. Unfortunately, I couldn't get enough patients accrued in all 3 arms, so I couldn't give you that signal, but I do have the signal of all the arms combined. So that is there. So this was a clinical trial for melanoma non-small cell lung cancer patients, 1 to 10 brain metastases. They have to have 1 or more extracranial site of disease for an abscopal response, and they have to be standard age, and they have to be able to give a consent, good performance status. And then the primary endpoint was the RTOG 9005 primary endpoint, which is no grade 3 or more CNS toxicity. So one of the first point when I did this trial was, is it safe? If you're doing such ablative radiation to the brain and you're doing immunotherapy, was it safe or not? That was primary endpoint. So yes, we met that endpoint. I'll present the results. We didn't have any toxicity. Number 2, do we actually see improved control rates? The answer is yes. I'll present the data with 95% or better. I think it's like 100% local control rate. And we have very good intracranial control rate. Then we look at extracranial responses and anywhere else extracranial progression-free survival. We look for all of those endpoints and overall survival endpoints. And then more importantly, we look at immunological readouts. So these patients gave blood before treatment and after treatment. And we look at the CD8 T cell that are Ki-67 high, and we see increases in that early on when we started radiation and pembrolizumab. And that actually correlates with the overall outcomes and survival. So this data was presented earlier on. So here's the actual results. So only 25 patients were treated because of small trial, single institutional, and half of them, because what happened when I started this trial, halfway through, dual checkpoints got approved. So back then it was just pembrolizumab was the only approval for brain mets. And I did radiation and radiosurgery at the same time. Halfway through my trial, by the time trial got launched, the landscape had changed and everyone started getting dual checkpoints. Matter of fact, when they were getting dual checkpoint, and they were failing, they were coming back to my trial. So which isn't a clean trial because you have half the patients that are more likely to respond. The other half the patients are actually worse outcomes because they already failed dual checkpoint. You bring them in, you don't expect to see good results, but in reality, they actually see good results, which also highlight that radiation can overcome resistance to anti-PD-1, which I have data for to my mouse work I could show you, but that's a different talk. But regardless, we've looked at all of these patients, so 25 patients, and then there was no CNS toxicity grade 3 or more, 0% toxicity, so it was safe in the brain. The local control was actually quite impressive. In the radiation area that I'm radiating, 96%. I can tell you we don't see 96% local control rate if you don't add immunotherapy. It's much, much lower. Most data will show 60 to 80% control rates with SRS alone in the brain. I actually hit 96% in my trial. The overall survival was actually 66.2%, which was almost doubling the historical survival for these patients, where the survival for them was like only 30% in 1 year. And here we're seeing 66%. So very, very impressive. And what we did was we stratified patients that were treatment naive, those that never got immunotherapy before. The outcomes even actually much better than that, than the patients that were previously failed or they got previous dual checkpoint or previous therapy, which should have been the right trial, but I couldn't complete that. But regardless, we see benefit in both of those cohorts. So that was pretty impressive. And the main important thing is look at intracranial benefit. which means if I'm rating the area in that the radiation is targeting, what happens to the rest of the brain? Do I still see benefit in the rest of the brain? So what I actually see is intracranial progression-free survival of 76.2% at 6 months, which is on par with the dual checkpoint alone data that was published in New England Journal of Medicine. So my take is I really think that SRS and PD-1 alone combined would be just as effective as dual checkpoint if you have the right cohort. And I'm actually trying to champion that phase 3 trial at the national level, but a lot of medical oncologists and there's a lot of biases about it, things like that. But regardless, this is the data. So what I highlight is exactly my point. If you look at our data, pembrolizumab plus SRS for treatment-naive patients, our intracranial benefit is 69.2%. And at 6 months, it's 76.2%. All right. If you look at Tavi's data from MD Anderson with 94 patients, where they did ipi-nivo alone, and there were very small brain metastases, limited brain metastases, their data is 57% intracranial benefit, or intracranial progression-free survival at 6 months is 64.2%. If you look at these two data, it almost shows you the signal is almost on par with dual checkpoint. Also keep in mind, this will be a lot less toxic for your patients. Because with dual checkpoint, you're looking at 50-60% autoimmunity. With SRS and PD-1, hardly any autoimmunity at all, extremely, extremely low. So to me, I think this is something that I would champion in the long run. All right, that's melanoma setting, because I treat melanoma patients. What about a different setting? Does this translate from one cohort of patients to a different setting, like multiple myeloma patients? So I treat a lot of multiple myeloma patients with radiation, and that's palliative. Keep in mind, relapse refractory myeloma patients, I, as a radiation oncologist, tell them, I cannot cure you. I can only give you palliative radiation. So in this, I ran a trial, anti-PD-1, with radiation 8-1 for relapse refractory myeloma patients. Once again, pembrolizumab alone never worked in these patients. So they had about 3 lines of drugs. They failed. They did Keynote 13 was done. 0% response rate, 0 out of 30 objective response rates when they did pembrolizumab alone. They also ran Keynote 183 and 185, which was a phase 3 randomized trial, where they did pembrolizumab with dexamethasone and pomalidomide or lenalidomide. So Keynote 183 and 185. Both of those trials were negative. Matter of fact, they were toxic to the point where they had an increased toxicity, where there was an increased number of deaths, and therefore they said, no, we cannot combine pembro with either of those, stop these trials. So once again, pembro alone didn't work in this cohort, right? In my trial, I'm doing radiation and pembro, and my patients are worse because they're failing on average of 5 different lines of therapies before I put them on my trial, okay? So this is my trial, phase 2 pilot trial, and then we have 18-year-old or older, ECOG standard 0 to 1, with one area that I'm going to radiate and some area outside that I'm not going to radiate. I want to see what happens in abscopal response. So in this one, I found a 20% abscopal response, which is encouraging, and I'll present the data in a second. The primary endpoint was toxicity. Is it toxic or not when you combine the two? And the secondary endpoint were like IMWG criteria. Do their IgG kappa, lambda labs drop, go normalize? Do we see toxicity at 6 and 12 months? And more importantly, do we see immunological activation or not? So that's what this was about. Once again, 25 patients treated from June 2018 to 2021, and a majority of them were Caucasian. That's the patient population we usually see with myeloma. And 64% were ECOG 1, and the mean age was 60 years old. Now this is the important part, take home. These patients failed 5 or more lines of systemic therapies. So you don't expect to see any benefit of this. Adding radiation to them, you expect to see 0% response rates. Even pembrolizumab, that didn't work before. So my medical oncologist didn't actually want to refer them to me. They're like, it's a wasted effort, wasted time. But they were unique patients. They felt like, hey, there really is no therapy left. So why not get on Dr. Khan's trial? Maybe it'll work, maybe it won't. And these patients selected themselves to get on the trial. And these are the different drugs they failed. They failed CAR T cell, they failed autologous stem cell, POMDEX, RVD. So they failed all the big guns you can imagine, and they're getting on my trial. Once again, safety was met. We did not see any grade 3 or more radiation-related toxicity in the areas that was being radiated. We didn't see any increased autoimmunity, out-of-field effects. So the take-home point was it was safe, number one. That was the primary endpoint. Number 2, the partial response rates. So we had 7 patients that actually had objective responses. So 7 out of 25 is a 28% objective response rate. So about a 30% objective response rate is actually considered a home run for these categories. If you ask most medical oncologists that treat these patients, they say if you got any therapy that has a 30% objective response rate, that's a home run. that needs to be investigated further. So our medical oncologist team, we're very excited about this. And I get a lot of patients now that fail CAR T cell, or they have oligometastatic disease, or they have limited burden of disease. I'm radiating them. So it's to try to get rid of metastatic disease and trigger immunity in these. Once again, this was overall survival, 6 months, progression-free survival, and this was the immunological readout. Okay, so what we did show that those patients that were responding also had activation of CD8 T cells, and that activation took early in the process of radiation than it would have otherwise. And then those patients that had activation of the CD8 T cells also then had an abscopal response. 20% of patients had an abscopal response in this trial as well. And this is an example of an abscopal response where 5 out of 25 patients have an abscopal response. And then 4 out of these 5 also has CD4 and CD8 T cell activation, which drives home the point that radiation is triggering CD8 T cell immunity, CD4 T cell immunity. That's turning into improved outcomes with these patients. And if you want to read more about it, this is our Lancet paper that just came out, I think maybe 6 or 8 months ago. Is in press. You can read about it. It was nice. And this is the what they call the swimmer plot, where look at this patient number 32 that had a response, and the response was maintained. So that's a very good partial response, or they had a complete response, like these blue lines were complete responders, or they had very good. So you can see all the responders and how long that response lasted in these patients. And some of these patients were not followed up long enough, but some of them are still being followed. So we presented all this. So the Lancet oncology reviewers actually, the Lancet hematology reviewers actually liked this paper and said, yeah, has some value and merit to it. So they accepted it. All right, the next 5 minutes, I'll talk about turning off the immune system, which is also important. During 2019, 2020, we had COVID come through. There weren't any therapies. These patients' biology was there was a lot of inflammation in the lungs. And what you see in black lines are actual mouse models and data that shows radiation can reduce all of these things in mouse models. It can reduce IL-6, it can reduce inflammation, it can reduce TNF alpha, beta, it can increase IL-10. So there's all these things that were being learned about during COVID. And my argument was radiation should reduce inflammation, especially very, very low doses, like 1.5 gray or less. Okay. And I went to my IRB. I said, look, I want to do this trial. We didn't have a lot of therapies. We didn't have any mouse data specifically with COVID. And no one in the world had that data. So my IRB was like, Dr. Khan, we believe you. We understand. So it was a scientific leap of faith where multiple arguments were made with IRB. IRB was like, okay, Dr. Khan, you can do 5 patients. If you show data on those 5, we'll let you do 5 more. If you do that, we'll let you do 20 more. After 20, we'll let you do 100 more. So that's how I started this. So this is a true scientific leap of faith that low doses should cut down inflammation. And then we ran those trials. So this is the Rescue 119 trial that radiation is low dose of radiation, not what I talked about in my earlier slides, but low doses where it cuts down inflammation. And this was us on April 24th of 2020 when COVID was around and it was brand new in the US. This was the day we're actually going to be treating the patient. So we went through learning how to put masks on. Dr. Hess and I were co-PIs. We were wearing, and here's me at the head of the bed. And this is actually a mock therapist that evening. We're about to radiate. So we went through the whole process, how to clean the gantry, how to put the patient, how to transport the patient, and how to keep each of us from getting infected. Keep in mind, this is life-threatening, life-risky for all of us. And we don't have vaccines. We don't have all those things available at that time, therapies. We didn't even know what therapies are going to work. So we're risking our life in April 2020 to sort of show radiation can cut down inflammation. And we did this. And here's our data. So we presented this in the Red Journal and Cancer and multiple other papers, and we presented in national meetings where low dose radiation cut down inflammation. And here's the data, like here's an x-ray as well. Day 2, you see all this infiltrates. And look at day 9, all those infiltrates are much, much better and clearly on x-rays. And also you see the time to recovery, which means how quickly the patient got out of the hospital. Here we have time to recovery of 3 days. So all of our patients are getting out of the hospital an average of 3 days. Whereas if you look at the control, they're still in the hospital even 30 days out. They're not getting out. So we see a 3-day versus 12-day improvement, and that really was all over the news. And we got actually for you guys, I'm sure you know Al Khalij, right? That's a paper, I think, newspaper in Saudi Arabia. So we even made it Saudi Arabia news back then. But Science, we were in CNN, Forbes, multiple articles. So we published several of this data. And here's a 40-patient trial that showed improved outcome with low dose radiation versus controls. We prevented patients from getting on intubations. And this was published in the Green Journal as well here. See, back then we had a lot of criticism. There was a lot of mouse data and people criticize us on Twitter, but I'm like, it doesn't matter. Patients are dying. We got to do something. We got to move ahead. But it was based on other mouse data that I was able to make this hypothesis. But then when this data started to come out, so data from Gustave Roussy, Eric Dosch's lab from France came out, supported this thing, and he ran 3 different mouse models of causing ARDS in mice and did low dose radiation 0.5 to 1 gray and showed exactly what I had hypothesized, that yes, radiation cuts down inflammation. And then the question goes, was there a phase 3 randomized trial that showed this? Yes. In India, where I was giving talks and lectures about this, actually came forward where the WIN COVID trial came out, phase 3 randomized trial that further showed that yes, radiation reduces inflammation and improves outcomes. So you can read about this phase 3. This was also published in the Green Journal as well too. All right, now what are we doing today? Matter of fact, yesterday I was doing, actually this morning I came in, I was contouring. And what was I contouring? Arthritis. So I was treating my arthritis patient. I think we treated a couple arthritis patients now. So I think Germans and people in the UK and other places are already doing low dose of radiation for arthritis. But the Americans, we were very strict about not offering low dose radiation for arthritis. Now that after COVID-19, we saw this data, we saw this evidence, and we look at the evidence that's overseas in the European area, we're comfortable doing arthritis. So many hospitals across the US are now trying to do our low dose arthritis. And that's a different talk that I can give to you guys if you guys want to. Matter of fact, there's already evidence that is starting to emerge that maybe low dose radiation can cut down inflammation in Alzheimer's, because part of Alzheimer's is inflammation mediated. There's already sort of work in mouse models that are ongoing for congestive heart failure. So you can imagine where the field is going to go towards on understanding low dose radiation for anti-inflammatory effects, and anywhere else in medicine where inflammation is a problem, low dose radiation becomes an option. This is just some of my lab team. My lab team has changed over the years. I've got a bunch. I just haven't had time to update this slide, but these are the key players for a lot of this work. With that, I'll say thank you and take any question you may have. Thank you.
Thank you so much, Dr. Khan. This is amazing, really, and almost bordering on miraculous for COVID. And I would like to ask, the audience if they have any questions. It seems that any questions?
Yes, I think there's one from Dr. Al-Ghademi.
Oh, Dr. Abdulaziz, go ahead, please.
Yes, thank you, Dr. Khan. That was a fantastic roller coaster of RT and immunotherapy. So I think when we were studying for radiobiology for the ABR, we learned about the Joyner effect, where very low dose radiotherapy, ultra low dose, can dampen the immune system. Do you think that this is what is driving the anti-inflammatory effect of radiation? That's my first question. My second question is, I don't think he's on with us, but we have a radiation biologist here in Saudi Arabia, a friend of mine who did his PhD at Bordeaux, and he worked on models where they used, simulation models where they used particle radiation with high doses. And they noticed that the NF-kappa was related to the abscopal effect. Did you come across any biological markers like NF-kappa or some other biological markers or biomarkers that we can use to know if abscopal effect is working in the clinic? Thank you so much.
Yes, that's correct. So 2 things here. One is immune activation, which is NF-kappa B driven. You're correct. So there are papers out there that talk about NF-kappa B and how to modulate the C-gas stink pathway. The C-gas stink pathway is what we think is one of the premises by which the abscopal response takes place. And people that knock that out, and c-MYC or MYC amplification is another part of it that also plays in the abscopal response. So you're actually correct. We're learning about these genetic mutations and genetic biomarkers and figuring out how to sort of tweak those to try to enhance the abscopal response. So the future trials are exactly need to focus on those pathways. That's exactly correct. So the whole C-gas stink pathway that happens within the tumor cells and the tumor environment, and then above and beyond that, what happens with CD8 T cells and macrophages, and what are the different checkpoints that are turned on or turned off and activating these, I think is going to be important. And I think that's where the holy grail is in enhancing the abscopal response. So you're actually right. Now, the other question you asked about in inflammation, you're actually correct. So, so if you look at the slide, I didn't go into a lot of biology slides, but if you look at the this COVID trial, so IL-6 is one of those cytokines. So what happens is when anything in the body comes in, like a virus, or in case an injury or something like this, these things get trapped. So these are macrophages, and these macrophages are M1. M1 macrophages are inflammatory, and you need to convert it from M1 to M2 macrophages. Because when you have these M1 macrophages trapped in that environment, they will recruit other dendritic cells. They'll recruit other immune cells like lymphocytes into that area. And what that does is sets off the cytokine cascade of IL-6 being increased. When IL-6 goes up, you have more and more inflammation that continues on. And what you want is IL-10, which is produced by M2 macrophages, which reduces inflammation and reduces a lot of those things. So you see this immune system that gets revved up. And the whole thing with low dose radiation, we know lymphocytes are very sensitive to radiation. Low doses will wipe them out, clear them out, and then reprogram the immune system. What happens is when the reprogramming takes place, the anti-inflammatory cells are in there, so M2 macrophages are in there, that will then reduce IL-6, increase IL-10, and also interferon gamma and some of these other cytokines and alter. And this is what the hypothesis was. And you're actually correct. So this is what Dr. Gustav Rushi from Dr. Eric Dosch's lab, that's exactly what they did. So they looked at interferon gamma signaling, they looked at IL-6 signaling and IL-10 signaling, and they showed that interferon gamma is reduced, IL-6 is actually reduced, and IL-10 is actually increased. So what happens is that ratio from inflammation actually tips to anti-inflammation towards a normal lung, right? And that's what this showed. And they did it in 3 different mouse experiments. Where they did it where they injected lipopolysaccharide into the mouse, into the nose to cause ARDS. That's one way to do it. They also did H1N1 flu. They injected into the lungs to cause ARDS, acute respiratory distress syndrome, like pneumonia type symptoms. And they did poly-IC, which is a toll-like-3 receptor. So 3 different methods of causing ARDS. And they show low doses work in all 3 of them and actually converted inflammatory lung into anti-inflammatory lung. Now, what I did present was similar data that comes out of Germany and other places with mouse experiments that shows exactly that similar biology is playing a role in arthritis and whatnot. So, and I think the similar probably plays a role in Alzheimer's, CHF. That has yet to be explored. But I think arthritis, we're comfortable with it. And I'm already seeing good responses in my arthritis patients. But a great question. Thank you.
A question from the audience, from Dr. Mohammed Al-Mahmoud. What about constraining dose to major vessels and bone marrow to prevent affecting the immune cells? How strict should we go?
Yeah, I think we should be very strict about it, honestly, like as low as possible. So there's already data coming out, I think from MD Anderson and others, where they're looking at esophageal proton radiotherapy, where they're showing that if you reduce the lymphocyte burden, the white blood cells, and some of the hematological damage, these patients actually do better. So there's already early data coming out of this. And in the bone marrow, I'm on the ILROG and work with a lot of the ILROG members. So we're actually recommending to reduce your bone marrow doses as low as reasonably achievable when you're doing pelvic radiation, things like that. So we are definitely putting bone marrow as one of the constraints. Now, what that number is, we are going to learn. And I think with the whole NRCP or these sort of biological models or physics will help us guide that in terms of what are those quantic guidelines we need for bone marrow. But I think that's probably coming.
Another question, yeah, from Professor Yasser Bahadur. What about the risk of second malignancy with low-dose radiation therapy?
Yes. So there's a paper in the Red Journal in 2002 by Dove et al. That looked at the German guidelines on arthritis, and they looked at thousands of patients that were radiated. Actual clinical outcome, they say we didn't see any risks. But with theoretical modeling, especially for patients 40 or older, what they did say that there may be a 0.1% lifetime risk. And that majority of risk is a basal cell. As you know, basal cells are very curative anyways. So 0.1% theoretical risk, long-term lifetime. That's what I'm telling patients. But then again, if you have a patient, like I treated one patient, my first one was an elderly lady in her like mid-50s who had arthritis in her hand, but she couldn't even open bottles, right? And she couldn't even drive, and she has to wear a brace and she couldn't even type. So functionally, quality of life is terrible for her. And her VAS score was a 9, which means she cries almost daily. And then she's failed 4 or 5 different lines of drugs. So to me, is that 0.1% risk an issue? And after radiation with the 3 days, 1.5 grade, she comes in, she's opened the water bottle. She's like, Dr. Khan, I'm not wearing a brace. I'm driving on my own. I'm able to write. I mean, to me, the quality of life is much more important for her now than a 0.1% lifetime risk for a basal cell, which we can cure anyways. So anyway, so that's what I think. So I think if you select the right patient, the benefits outweigh the risks.
Actually, it seems that the agenda of the upcoming Astro reflects the growing interest in benign disease and the treatment with radiation therapy as well.
That's
There's a
correct. Very
question.
relevant.
Yeah, there's a question from Dr. Fahad Ruwais. Concurrent chemoradiation with concurrent immune checkpoint inhibitors did not improve outcomes in non-small cell lung cancer, Pacific 2, and small cell lung cancer, NRG LU005. However, in cervical cancer, Keynote A18, the combination did improve outcomes. Any explanation?
Yeah, and I think that's a good question. So to me, I think part of it has to be trial design, you know? So to me, I think number one, when you do large fractionations and you prolong the treatments, you're wiping out the cascade. This is a kinetic process. It's not a static process. We turn the immune system on, it's going to stay on. So every time you do radiation, you cause immune cells to infiltrate into that environment, day one, right? Then you radiate again, day two, you wipe out the immune cells that are moving in. Day three, you're wiping out again. Day four, you're doing the same thing again. So to me, I think one is fractionation. So in that JITC paper that I published in 2018 that talked about fractionation, how fractionation is bad because you're wiping away the tumor cells that are trying to engage the immune cells. So that's number one. Number two, you have to design the trial to understand where the activation takes place. If the majority of the activation takes place in the tumor environment, then fractionating that will not be good. But if the activation takes place in the lymph nodes, and you're also radiating the lymph nodes, and you're destroying where the activation takes place, that's not good either. So to me, I think we still, and I think each cancer is going to teach us that the design to optimally enhance the immune response is going to be very different. So what I do in melanoma is going to be very different. And if you notice in melanoma, I did the hyperfractionation 6 or 8 times 5. So I limited my number of fractionations. I didn't do 21 as much. But in myeloma, I only did single fraction. That was it, because I didn't want to radiate again, right? But I saw a systemic effect by just one fractionation. That's it. So to me, I think with non-small cell lung cancer, I think we need to be cognizant about the number of, and I think SBRT's approach, I think there is a SABR trial. I don't know if you looked at SABR. I think there's a SABR from MD Anderson and another institution that when you pull the data together, it actually has an overall benefit for metastatic non-small cell lung cancer where you did pembrolizumab or anti-PD-1 with SBRT. So that showed a benefit.
Excellent. Back to you, Dr. Abdulaziz Al-Ghamdi.
Yes, we were approached recently by our colleagues from nephrology. We have a sizable transplant program, and they were asking us about the total nodal irradiation for patients considering kidney transplant. Personally, I haven't been, in terms of the anti-inflammatory effects of radiation, we're not that well versed as radiation oncologists, but I refer to your expertise. Do you think that this is something might come down the line where we can use radiation in preventing rejection for transplanted organs? Thank you.
Yes, great question. So I'll give you two answers. Number one, the answer is absolutely yes. And matter of fact, Emory is standard of care. We've done kidney transplant subtotal nodal radiation, but very, very low doses. We haven't done it recently, but we have done this in on and off whenever they feel like they don't want to put patients on long-term immunosuppressions. So that is standard routine, not a problem. Okay, so you can do that. Number two, I think more importantly, I think another area that you guys will see is CAR T cell. So I don't know if you in Saudi Arabia, you guys are starting to, or in the Middle East, you're starting to CAR T cell or not. But if you do, one of the things about CAR T cell is you have to do what's called lymphodepletion, right? And with lymphodepletion, that's where a lot of the toxicity comes from for these patients. To me, I think that's another area that I think we could potentially, as radiation oncologists, do subtotal nodal or low dose radiation to cut down lymphodepletion and have less toxicity, and then allow them to get CAR T cell. Matter of fact, there's a second part of that where low dose of radiation, which is the Rath-Scopel effect, actually takes the tumor environment that are shielded from the immune system, open them up for better CAR T cell attack. So I think you might win doubly there. And I think that's an area that I've been sort of championing as well. Haven't had the bandwidth to do the clinical trial, but I think that's an area that we're headed towards in the future. But great
Excellent.
question.
Excellent. This will be the last question, and then we'll wrap up. Which criteria are you currently using for selecting patients with benign conditions for low-dose radiation therapy?
Great question. So right now, in the U.S., and arthritis is 40 or older. As long as they have failed some primary intervention like NSAIDs or anti-inflammatories, or they failed physical therapy, they're eligible. You don't want to do steroids because steroids are bad. So that's number one. Number two, with benign conditions, so we're doing, acoustic neuroma, schwannoma, all the standard of care stuff we do anyways. So we do all that. I am now starting to xerostomia. So patients with ALS. So my own team, like my, people, neurologists, or these sort of people that specialize in these sort of neurological disorders, they're telling me, look, these patients that have ALS, their xerostomia is so bad that they get aspirations, they get issue with swallowing. So I'm actually going to be starting treating those patients as well too. Now there's already evidence for it out there, but there are case reports and things like that. To me, as long as there's clinical case reports and some good rationale where the benefits outweigh the risks, I'm okay with doing that.
Thank you so much, Dr. Khan. It was a privilege and pleasure to have you with us it's a fascinating subject, and I'm sure everybody who listened to you today, got excited about it and will start looking into it. Now, there are a few questions that probably, because of the time constraints, we'll have to skip. Do you mind if people email you with questions,
Sure.
if you don't mind? And so I leave the podium now for Dr. Abdulaziz.
Sure, be happy to respond via email. That'd be great. Thank you.
Thank you so much,
Thank you.
Dr. Khan, for giving us this great talk. I think people truly enjoyed the talk, and we look forward to seeing you, inshallah, in Saudi Arabia in a few weeks.
I'm looking forward to it. Looking forward to meeting you guys in person if you're around. So thank you so much for the opportunity.
Thank you. Thank you.
Take care.
Bye.